Hello everyone, today we'll be talking about hypovolemic shock. So shock means hypoxia at the level of tissue. Hypovolemic shock, it is the most common type of shock that you see here. It is the most common type of shock and it is because of hemorrhage. Mostly it is because of hemorrhage. So the hemorrhagic shock that we are talking about, it is maybe due to concealed hemorrhage or it may be due to revealed hemorrhage. Okay. Now, revealed hemorrhage, when the bleeding is seen from outside, it may be a arterial origin. It may be arterial origin. That arterial bleeding can be because of total transection of the arteries, means the arteries they are totally separated from each other, or it may be because of the laceration of the arteries. Okay, so there is a lacerated wound over the artery. Now, as a result of this bleeding, there will be compensatory mechanism, that is vasoconstriction. So in case of transected wound, as the ends will be constricted, there will be less bleeding. But in lacerated wound, because of vasoconstriction, the bleeding will increase because there will be gaping of the lacerated wound on vasoconstriction. Also, the revealed bleeding can be a venous bleeding. Venous bleeding means there is oozing of the blood. So the body has many time for compensation. So this venous bleeding, if it is happening, so there will be late presentation because the body has enough time to compensate. Now, concealed bleeding, that you have to know from here, that if there is close injury to the vital organs, basically like in the neck, thorax, abdomen, pelvis, or even very important, long bone fracture. Long bone fracture. So in these cases, you will be having concealed bleeding and enough to cause hypovolemic shock. But isolated intracranial hemorrhage cannot produce that amount of hypovolemic shock because your cranium do not accommodate that amount of blood to produce hypovolemic shock. It is a very limited space. Now primary hemorrhage, secondary hemorrhage, and reactionary hemorrhage. Okay. So the primary hemorrhage means it is the bleeding that is happening during OT. So it is an intraoperative bleeding that is happening, is your primary hemorrhage. Secondary, that happens at 5 to 7 days of the operation, 5 to 10 days of operation, and that is because of infection. Reactionary means 4 hours to 24 hours. Within a day of operation, if there is bleeding, that is reactionary hemorrhage. Okay. Now this reactionary hemorrhage happens because of two reasons mostly. One is the slippage of ligature. Slippage of ligature. The next point is it is dislodgement of the hemostatic plaque. Now why that is happening? It is because, see, during OT the patient is under anesthetic medications which generally decreases the BP to decrease the blood loss on table. But once the patient is shifted to the ward and the anesthetic medications action is over, then because of increase in BP, that can dislodge the hemostatic plaque also and can cause this reactionary hemorrhage. That is very, very important. As I mentioned, that secondary hemorrhage that happens because of infections. There is sloughing of the artery or the vessels secondary to infection, which is important. Okay. Coming to the classification of hypovolemic shock. The classification of hypovolemic shock. So we have four classes, class 1, class 2, 3 and 4. It's very important to remember and very easy to remember also. Class 3 and class 4. Okay. Now, in class 1, all the vitals are normal. In class 1, all the vitals are normal. We'll be discussing and we'll be completing the table at the end of this discussion. And in class 4, the vitals are not recordable. So in class 1, every vital is normal. In class 4, they are not recordable. So if I have to say what is the amount of blood loss, it is up to 15% is class 1, up to 30% is class 2, up to 40% is class 3, and more than 40% is your class 4 hypovolemic shock. Okay, that was a question here. Now here in class 1, it is 400 to 500 ml blood lost. In class 2, it is up to 1 liter. Okay, up to 1.5 liter is class 3 and more than 2 liter is your class 4 hypovolemic shock हेमरेजिक शॉक में इतना ब्लड लॉस होता है. इन क्लास 2 there is compensatory mechanisms which is activated because the body actually have the time to act on that. So the sympathetic system will be activated as a compensation. Once the sympathetic stimulation is there, norepinephrine, epinephrine will be released. There will be tachycardia, which is the first indicator of hypovolemia. Also, because of this, there will be peripheral vasoconstriction, and because of peripheral vasoconstriction, diastolic BP increases. Vasoconstriction lead to cold peripheries because there is decreased blood flow in the periphery. So the peripheral blood will be shunted to the vital organs. There will be shunting of the blood to the vital organs, maintaining the cardiac output and systolic blood pressure. Maintaining the cardiac output and systolic blood pressure. So that means here the pulse pressure, which is equals to systolic minus diastolic, the diastolic is increased and systolic is same, so pulse pressure becomes narrow and urine output is mildly decreased. Okay, the patient otherwise just feels thirsty or anxious, otherwise okay. Coming to class 3 hypovolemic shock. There is 30 to 40% of the blood which is lost, and because of this the body will try to compensate. But again I am telling, as the loss is very high, so the compensatory mechanisms can't stabilize the body. The sympathetic stimulation cannot maintain the diastolic blood pressure because the volume is so much low here, so the diastolic blood pressure eventually decreases. Because of so much hypovolemia, the systolic blood pressure is also decreased, and this is the first stage of hypovolemic shock where the systolic blood pressure is decreased. So the pulse pressure, which is systolic minus diastolic, also now narrow. So what about the respiratory rate? As I told you, till now the respiratory rate was normal, but in class 3 there will be gradually tachypnea developing. Urine output, please remember this is a decompensated stage. That means the compensatory mechanism cannot help the patient. So it is a decompensated hypovolemic shock. Here the patient will be confused and the urine output will be low, very much low. Okay, very much low. Oliguria will be there. So if I have to consolidate all the things here, stage 1, 2, 3 and 4 of hypovolemic shock. So first we'll be talking about the blood loss. So 0 to 15%, 15 to 30%, 30 to 40% and more than 40%. The amount of blood that is lost is around 400 to 500 ml, around 1 liter in stage 2, around 1.5 liter in stage 3 and more than 2 in stage 4. Now we'll be talking about, see, what is your class 1? It is basically that blood donation. Blood donation camp mein we actually donate blood, and where we actually donate 4 to 500 ml. Stage 2 compensated, stage 3 decompensated shock, and stage 4 is basically where there is no response. So it's a patient who is just going to die if you do not resuscitate properly and immediately. Okay, next coming to the systolic and diastolic blood pressure. As I told you, in stage 1 everything normal, stage 4 mein not recordable. Systolic BP decreases fast in stage 2 and systolic BP decreases in stage 3. Okay, so the pulse pressure is normal and here not recordable in stage 2, and stage 3 there will be narrow pulse pressure. Understand? Coming to the respiratory rate, everything is normal and not recordable, and here I told you respiratory rate increased, tachypnea in stage 3. Urine output, which is a very important clinical indicator, obviously, oliguria and anuria. So stage 3 oliguria, stage 4 mein anuria. Very important thing, that how we are going to treat it. So in stage 1, we can just give oral liquid or ORS. Okay, that is also provided in blood donation camps. Stage 2 mein you have to give IV crystalloid, that is NS or RL, and you have to add colloid in stage 3 in decompensated shock. at 3:1 ratio. So IV crystalloid and colloid 3:1. But in stage 4, you need massive blood transfusion. We'll be discussing massive blood transfusion just after a few minutes. So in stage 1, there is as such no complaint. The patient's mental status is normal. Mild dizziness can happen, but if there is mild dizziness, then you have to stop the donation. Stage 2 mein patient will feel patient will be thirsty and anxious. Stage 1 is just a normal, you can remember. And stage 2, patient feels thirsty and patient is anxious. In stage 3, patient is confused. And in stage 4, it is unresponsive and patient is in coma. Now, to monitor the fluid resuscitation in shock, we have some indicators. The best clinical indicator that we have is the urine output. So, now here the goal for the urine output in adult is, in case of adult and in case of children is different. In case of adult, it is more than 0.5 ml per kg per hour. In case of children, it is more than 1 ml per kg per hour. It is the best clinical indicator, urine output, to assess the fluid resuscitation in shock. Okay, but the best indicator to determine the amount of fluid required in shock, that is pulmonary capillary wedge pressure followed by central venous pressure. We use Schwann-Ganz catheter for measurement of the pulmonary capillary wedge pressure. Okay, so it is the best indicator to determine the amount of fluid that is required to assess the fluid requirement in shock. Now, once we monitor, then we have to know till what point we should continue this IV resuscitation. So we have to know the end point of resuscitation, and that is measured by mixed venous oxygen saturation. Also, we can have the base deficit and serum lactate levels to assess the systemic perfusion other than MVOS, which is the best indicator. What is the normal value of mixed venous oxygen saturation? It is 50 to 70%. It is the normal value. Remember, in case of cardiogenic shock or hypovolemic shock, this MVOS is decreased less than 50%. But in case of septic shock, it is more than 50%. Why? What is the reason behind that? Why there is falsely elevated MVOS? Because in septic shock there is quick circulation, there is rapid circulation, so there is impaired oxygen extraction at the level of tissues. Okay, less extraction of the oxygen at the level of tissues, that is giving rise to false high MVOS. Let us discuss the indices now. So we have shock index, then we have modified shock index, and then we have something that is known as ROPE, rate over pressure difference. Okay, ROPE. The shock index is actually, it is the heart rate divided by systolic blood pressure. It is heart rate divided by systolic blood pressure. In case of shock, there is tachycardia, so the heart rate will increase. It is the initial response as a compensatory mechanism. So the heart rate will increase. And what happens to the blood pressure? There is hypotension. So the systolic blood pressure will decrease. So if it is, this ratio is more than 0.9, that actually denotes a higher mortality. That is a bad prognosis. But now we use modified shock index, which is most sensitive indicator. We have M, so it is heart rate by mean arterial pressure. So again, if it is increased, that is more sensitive, means there is higher mortality. It is the most sensitive indicator. Okay. Next is ROPE, that is rate over pressure difference, and this is denoted by the pulse rate divided by pulse pressure. Okay, again this pulse rate increases and pulse pressure decreases. The narrow pulse pressure happens in shock, and if it is more than 3, this ratio, that is a bad prognosis and indicates decompensation. Less than 3 means it's a stable patient. Okay. The last topic, that is massive blood transfusion. Okay, I told you in category 4 or class 4 hypovolemic shock, you have to transfuse the maximum amount of blood, you have to restore that. Okay, so massive blood transfusion. What is the definition of massive blood transfusion? It is transfusion of more than 4 units of blood given in 1 hour. More than 4 units of blood given in 1 hour, or more than 10 units of blood that is transfused over 24 hours. Over 24 hours. Also, if you replace the entire circulatory volume in 24 hours, the whole volume is replaced, whole or entire circulating volume is replaced in 24 hours, is also massive blood transfusion. Okay. So, what are the complications following massive blood transfusions? Complications. The complications can be because of rapid transfusion, and because of the rapid transfusion, what happens? There is hypothermia. Hypothermia. Okay. Also, because of rapid transfusion, there are febrile reactions can happen. This is the most common complications following any blood transfusion reaction. We can use leukoreduction filters. Also, anaphylactic reactions are important complications. To decrease hypothermia and febrile reactions, we can just slow the speed of transfusion there. Okay. In the stored blood, we have citrate as an anticoagulant. Okay. The stored blood has anticoagulant, that is citrate. So this citrate can chelate with the blood calcium and magnesium. Okay. That is present inside the body. So that can lead to hypocalcemia and hypomagnesemia. So hypocalcemia and hypomagnesemia can happen. Also, this citrate can cause, there is this citrate can cause citrate toxicity. Okay. And initially, because of the citrate toxicity, there can be metabolic alkalosis, but that is transient. Later on, that is important, that later on this metabolic alkalosis is converted to metabolic acidosis, which is very important. So we have hypothermia, hypocalcemia, hypomagnesemia, and metabolic acidosis. Okay. What about potassium? The stored RBCs are lysed inside the blood vessels, leading to potassium release and can cause hyperkalemia. Okay, and this hyperkalemia can also, the acidosis can also increases the potassium. Okay, please remember. So hyperkalemia, it was asked in question, and metabolic acidosis is also important. So now coming to the most important two complications following massive blood transfusion is TACO and TRALI. TACO and TRALI. TACO, CO means cardiac overload, that is transfusion associated cardiac overload. Now there is cardiac overload leading to facial puffiness and pedal edema. So you have to treat this overload with diuretics like furosemide. Okay. And next is your TRALI. TRALI is transfusion related acute lung injury. What is TRALI? That is ALT, acute lung injury. Okay. So here the patient's presentations is actually kind of ARDS, acute respiratory distress syndrome. Bilateral chest infiltrates are present on X-ray. There will be decreased saturation and increased respiratory rate. Now remember, this TRALI is because of presence of anti-HLA antibodies. This was a question asked. Now this TRALI should be treated as early as possible, because good recovery is only possible if it is treated early. Guys, next is the very deadliest complication that we have is the coagulopathy. And please do remember, it is the most common cause of death following massive blood transfusion. Okay, please do remember. And we have something where there is a triad that is set on in a case of trauma. So it is coagulopathy, hypothermia, and acidosis. This three, coagulopathy, hypothermia, and acidosis, is what is your terrible triad of trauma. It is the terrible triad of trauma. So if these three are present in a case of trauma, it is very difficult that the patient will survive even after proper resuscitation. Okay, to prevent that coagulopathy, as we are just giving PRBCs, so the patient is lacking coagulation factors and platelets, so we have to give FFP RDP with PRBC in 1:1:1 ratio. Understood? Now we have certain scores that help in deciding the massive blood transfusion, that is ABC score and TASH scores. ABC and TASH, that is trauma associated severe hemorrhage score. ABC score may have four parameters. One is there should be a penetrating trauma etiology with less than 90 mmHg systolic blood pressure and more than 120 heart rate, and the fast should be positive. Okay, so this is your ABC score. TAS is trauma associated severe hemorrhagic score. No need to remember the parameters. And one thing I would like to mention here is this febrile reactions. So here we can reduce the incidence of febrile reactions by using leukoreduction filters while we are actually transfusing. Okay, we have this pyruvate antibacterial filters are present. Ending the discussion with a dynamic fluid response. What is dynamic fluid response in shock? Okay, dynamic fluid response in shock. So basically, once we know that this patient is shocked, so we just give a bolus of fluid. So around, see, after giving 500 ml of bolus fluid, we assess the central venous pressure that should rise. Okay, we expect the central venous pressure to rise by 2 to 5 centimeter of H2O, and then if this is happening, that central venous pressure is increased, and after 20 minutes this CVP is normalized, that means the patient is a responder. Okay, CVP increased after bolus fluid, and after 20 minutes the CVP is normalized, that means this patient is responder. But supposing even after giving bolus fluid the CVP does not increase, there is no change in CVP even after bolus fluid, so that is non-responder. That is non-responder. Okay, so we have responder and non-responder. Now suppose after giving bolus fluid the CVP raised, but after certain period the CVP is not normalized, rather the CVP falls below the normal value. That means CVP is actually again turned to the pre-treatment value in 10 to 15 minutes. That is what is transient responder. Why there is fall in CVP? Because there is ongoing loss. So ongoing loss means the CVP will fall. That is transient responder. Non-responder means CVP is unchanged. There is no change. That means the rate of blood loss that is happening is actually more than the rate of resuscitation. In transient responder, there is ongoing loss happening. So the CVP is decreasing. It is not maintained. Okay, and responder mein there is no loss. So hope the funda of hypovolemic shock and massive blood transfusion is clear. Thank you.